And first we'll start with pediatrician prayer. Now I welcome our dynamic treasurer, Dr. R.V. Dashani, to deliver the pediatrician prayer, please.
Thank you, sir.
Yeah.
குழந்தை மருத்துவனின் நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது. எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றோம், நல்லனவற்றை உள்வாங்கும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ.
Thank you, Dr. Dashani, and respected our dynamic president, Dr. K.U. Suresh Balan, and President past Dr. Ramesh Babu, and President-elect Dr. Balashankar, and Dr. Thirumurugan, Honorary Secretary, and Treasurer Dr. Dashani, and our judges, Dr. Ramesh and Dr. Ramachandra Mohan, Dr. Srinivasan sir, and so I welcome on behalf of IAP TNC, I welcome central as well as state IAP office bearers, and as well as central EB members and state EB members also. And today I really welcome our chairperson, Dr. E. Arunachalam. He is currently head of the Department of Pediatrics, Government Thuthukudi Medical College.
Thank you, sir.
Dr. E. Arunachalam, sir. I welcome today's moderators, Dr. Lakshmi Velmurugan. I think he need not have introductions. She's a well-known, renowned teacher. And I welcome Dr. Lakshmi Velmurugan. She's currently Professor of Pediatrics, Institute of Child Health, Egmore, MMC. I welcome, madam. And I welcome Dr. Prasad. He is currently additional professor of Child Neurology Division, Department of Pediatrics, All India Institute of Medical Science, New Delhi. I welcome Dr. Prasad. I welcome all the learners and case presentation from Thuthukudi Medical College, Dr. Deepa Lakshmanan and Lavanya and Dr. Sudarshan. And yeah, on behalf of IAP TNC, I welcome all the faculties and teachers, and as well as students and postgraduate students all over India. And once again, on behalf of IAP TNC, I welcome all. Now it's over to Dr. Arunachalam, sir, please.
First of all, I thank IAP for giving our college this opportunity to present again in this live forum of pediatrician. So our IAP leadership are doing wonderful job. That is the clinical meeting conducted for PGs and UGs, and we are very humbled to say that we are doing it third time we are from our college we are presenting, and we hope we will do our best to this e-clinical meeting. So thank you again for IAP Tamil Nadu for giving us this opportunity.
Okay.
So we will go to the case.
Yeah, now I welcome Dr. Lakshmi Velmurugan. Please tell few words and.
Yeah, yes, sir. Good evening, everybody. I profusely thank IAP TNC President Dr. Suresh Balan sir, Secretary Dr. Thirumurugan sir, my beloved Dakshayani Treasurer, and our always our real friend Dr. Rajendran sir, who has been doing this program for the past 3 years. Mala vandalum, idi vandalum, veil vandalum, the program be ongoing with the same enthusiasm. I have done a lot of classes, but every time when I come, it is done with such great professionalism, and all specialists from throughout India he has been calling, and it's a great program, very useful to all the PGs and the UGs, sir. Thank you very much for the opportunity, sir. Hope we do justice for your program. Thank you, sir.
Thank you. And now I welcome Dr. Prasad. Please tell a few words, and followed by we can start presentation.
I'm thankful to IAP Tamil Nadu and especially to you, Dr. Rajendra. This has always, whenever I have joined here in this forum, it has been a very lively discussion. I'm very happy the way the MD students are being groomed at your institute. So it is always a pleasurable moment for me to be here and participate in the discussions. And I hope that I'll contribute to them and we can have a collective learning from this. Thank you, sir. Thank you, ma'am. And
Thank you,
everyone.
Dr. Prasad. Now you can start the presentation. Deepak, you can start your presentation, please.
Good evening, sirs and ma'ams. We, the postgraduates from Thuthukudi Medical College, are going to present a case about a child with involuntary movements. Rahul, a 7-year-old boy, was first born of third-degree consanguineous marriage, who is residing at Koilpatti, was brought by his mother, whose reliability is good. They came with complaints of frequent fall for 1.5 months, followed by abnormal movements involving legs, hands, and face, followed by emotional outbursts in the form of crying when he tries to do something, when he tries to do any activity.
Okay, Rahul. Okay, Deepa Lakshman. This is we know, all of us are aware that this case scenario, the whole thing is about a boy with involuntary movements, abnormal involuntary movements. Okay. Now, what is striking you in this first slide itself? What is striking you?
Age of the child, 7-year-old.
Age of the child is 7 years old. So,
7 years.
commonest involuntary movement which we see in pediatric age group, what do you think it is? What are all the involuntary movements we know of, and what is the commonest movement which we usually see?
We see chorea, ma'am, and then dystonia, ma'am.
Very good.
Ataxia.
Okay.
And tremors.
Tics.
Okay. So which is a common among these? Which do you think is very common movement which you have been seeing among the involuntary movements? Chorea. And what do you think is probably the commonest cause of chorea in pediatrics? Rheumatic or drug induced? These two. Okay. Now this boy, is it striking you? Is a 7-year-old boy. What is anything, whether it's a girl, chorea is more common, or pseudonyms chorea is more common in boys or girls?
More common in girls, ma'am. 2:1 ratio.
What is the ratio?
2:1 ratio, ma'am.
This is more common. And yes, for all cases, you talk about consanguinity, or for this particular case, you had something in mind and you asked for consanguinity?
To rule out inherited disorders, hereditary causes of involuntary movements, we asked, ma'am.
You asked for consanguinity. Okay, go ahead. And you had said the child has got some emotional outburst. That is the presenting complaint itself?
Yes, ma'am. The mother complained that the child is having increased irritability when he is not able to do anything.
So irritability is different from emotional outburst.
Crying.
Crying. So is anger towards mother, ma'am.
At what? Okay, maybe you will expand about it or talk more in detail about history of present illness. Proceed. Next slide.
Yes. History of presenting illness. The child was apparently normal before 1.5 months, after which the mother noticed frequent fall while playing with his siblings. Frequent fall was insidious in onset and increasing in nature. After the fall, the child was able to get up by himself. It is not associated with any loss of consciousness or any weakness of any limbs. Shall I go to next slide?
Yes.
History of the child had history of abnormal movements, which involves all the 4 limbs, face and mouth, which is present when the child is awake, and it gets aggravated when the child tries to do any work, and it classically disappears when the child disappears during sleep. The movements were involuntary, rapid, purposeless, jerking, and a non-repetitive movement which flows from joint to joint. The severity of the movements was increasing nature, which was enough to cause the inability, inability of the child to walk, stand, and sit.
Okay.
The child
no, back. Okay. I'll ask a few questions, then I'll ask Dr. Prashant also will ask you a few questions. Now, you have seen abnormal movements involving all 4 limbs. Okay. If it is symmetrical, I mean, movements were symmetrical or asymmetrical.
Asymmetrical.
It was more, Sudarshan, it involved one limb more than the other limb, or upper limb and right upper limb and left upper limb was more involved, or unisymmetrically involving all 4 limbs. That I want to ask you. And you have clearly told me that the movements disappears during sleep. That is a very important point which you have brought out. Can you tell me one involuntary movement which does not disappear during sleep? All involuntary movements disappear during sleep except
hemiplegia, myoclonus, and then seizures, Restless leg
Seizures,
syndrome.
excellent. Only
Seizures.
involuntary movement which does not disappear during sleep is seizures.
Seizures.
All other involuntary movements disappears during sleep. Okay, that is okay. Now the second question which I asked you was whether it was symmetrical or asymmetrical, and does it carry any significance? For example, how do you classify chorea as?
It's a symmetrical movement, ma'am.
involving
No,
all the four.
No, how do you usually classify chorea? Chorea வந்து நம்ம எப்படி classify பண்ணலாம்? Primary, secondary அப்படி classify பண்ணலாமா?
Yes, ma'am. Primary, secondary.
Secondary. Okay, what is characteristic? Primary chorea common cause another. What is the common cause of primary chorea?
Inherited causes.
Very good, very good.
Huntington's.
Secondary is usually acquired chorea or
Acquired chorea,
causes of
secondary.
acquired chorea. Among these two, primary and secondary chorea, which is symmetrical, which is asymmetrical? Primary choreas, how are they? Usually, the genetic cause of chorea are usually primary is symmetrical. Okay, very good.
Symmetrical chorea.
Okay, now secondary choreas can be asymmetrical.
Yes,
Now
ma'am.
this child has acquired only now. You are thinking in terms of acquired chorea.
Acquired.
It has involved all four limbs, which shows the severity. Now you want to call it a you want to call that a symmetric or asymmetric. All it is equally involved, or any you want to quantify that, or you want to qualify your statement
Symmetrically involved.
Equally involving
Equally
all
involving
limbs.
all the limbs.
as far. Okay, it involves both the limbs equally. Okay, sir, Dr. Prashant, you'd like to ask something?
Yes, thank you, ma'am. So are you done with the description of the movement disorder that you are talking about?
What
Is it complete? You want to tell me something else also, or is it complete?
description of dance like
No, do we have any other slide which also speaks about the movement disorder, or this is what we are going to tell
so in the examination part,
Next slide, pa. Next slide. Go to next slide, pa. Next
about
slide, pa.
history? Okay, so
shall
okay,
we
you
present?
complete it, then we'll go back to the first slide where you started with your chief complaint.
Yes, sir.
So I don't want the negative history right now. Okay. So whenever we start any history in neurology, it is always better to give some information about the child of which we are talking about. So I would
Yes.
have liked you to begin that there is a 7-year-old child which is going to a normal school. Which grade he is going? Is he a right-handed or a left-handed child? Okay.
Yes, sir.
So this much information is required. And
Yes,
then
sir.
you say that there is a insidious onset or acute or a subacute onset of complaints which were in the form of the things that you have enumerated.
Yes,
Now
sir.
now there is some flaw with the presenting complaint that we are talking about here. So so let us not keep this thought process in our mind ki this is a syndrome chorea child. Let us take this as a child who has got some abnormal movement. So how are we going to describe it? How are we going to describe the associated features so that the person who is listening to you comes to a conclusion that this is syndrome chorea and nothing else? So, so we need to start with something as a null. Everything is null here, and then we start building up the story so that we conclude that this is syndrome chorea and not missing out on any other differential which can also be a possibility. If not in the case, then maybe in the next case which we are going to see. Okay.
Yes.
So
Yes,
now your
sir.
first complaint, that means this was the first thing that was noticed by the family, that there are frequent falls happening for the last 1.5 months.
Yes, sir.
Okay. And then
Yes.
you say that there is abnormal movements that are happening. So you have forgotten to tell me the timeline for this complaint.
Sir,
Within few days.
within 5 days, the mother noticed, sir. Within 5 days, after frequent falls, the mother noticed abnormal movements of the legs, or that abnormal movements, sir.
Okay, so this abnormal movement as per you came later.
Yes, sir.
Yes,
Yes,
sir.
sir.
So what was the reason of falls here then?
Sir?
What was
What
the reason
caused
for
that those falls if the movement started 5 days later? What led to those falls?
Sir, hypotonia, sir.
Very good, excellent.
Hypotonia.
Yeah.
Okay,
Yes.
so you say that there was significant hypotonia which is there.
Yes, sir.
So this hypotonia was paroxysmal or there was persistently the tone was hypotonic as per you?
Sir, Paroxysmal, sir. Not all the time the child was falling, sir.
So you can you think of a possibility, a disease which will cause episodic hypotonia?
Any other cause for?
Hypothyroidism.
Other causes.
Other causes.
No, in this
Episodic-
context, you say that there was fall which started, and after some days you started to have abnormal movements. So
Yes, sir.
possibly what is happening here, that these falls are also getting contributed with your abnormal movements, and there is
Okay, sir.
almost a simultaneous onset, which the parents perceive that it is falls which
Later.
began, and later on this. So instead of just reporting it like this, I would have reported it as there were episodes of frequent falls as well as
With abnormal
involuntary abnormal movement involving the appendages, that is legs and hands and face, which started simultaneously round about 1.5 months back. Now it is very difficult to then actually quantify which actually came first.
Okay, sir.
The same was associated with emotional outbursts.
Yes, sir.
So these behavioral issues, they actually precede the appearance of extrapyramidal movements in majority of disorders.
Okay,
So
sir.
this will not come later. This must have been there. So once we have taken a history, now we have to act not like an NDTV reporter talking about what the patient has directly told you. Now we have to apply our mind also, because the parents will tell you what has been most devastating for them. And the most devastating for them would be what? The kid is
Abnormal.
now and then.
Movements.
So that is why they said that it is fall that was there at the onset. But truly speaking, if you go in detailed HUPI, if you go back to the parent and ask the history, you will see that some emotional liability started. There were some abnormal movements that were happening. And simultaneously, there were some falls which were happening. Okay. So now
Okay,
let
sir.
us go to the next slide.
Yeah, as sir said, you could have qualified your first sentences, developmentally normal child, a
Yes, sir.
right-handed, school-going child, born to third-degree consanguineous parents, has come with the complaints. Those points you could have added. Very good. Yes.
Thank you. Thank you.
Yes.
Thank you, ma'am.
Proceed.
Okay. So here, so how did the things frequent falls while playing with siblings and all? So whenever you have some extrapyramidal movement or pyramidal movement or seizures or any form of paroxysmal activity, so first you have to tell how did it actually start, then how did it reach to the nadir, was there any increase in severity, or on the first day itself there was a maximum involvement that was there. Was it so that it started with paroxysm, episodes of these movements happening? Possibly that was the case, that was associated with falls. And then later, after a few days, there was a continuous involvement. Every time whenever the child was awake, there was movements which got aggravated with activity. But still, even in the baseline, when the child was sitting or doing something, there was some frigidity, some movements that was there in the upper and lower limbs. So this much information should come up whenever you have an extrapyramidal or any form of movement disorder. What was the onset like? How did it progress? And as ma'am rightly said, was it symmetric to begin with? Was it asymmetric to begin with? Then after, once the nadir was reached, still the asymmetry persisted. And then you come to the functional ability of the child. So how much functional ability is getting hampered by these problems with the child is having? That will tell you the severity of the disease.
And
Yes, sir.
Dr. Deepa Lakshman, Dr. Ramesh he has asked whether the symptoms are worsening, improving, or static. In any neurological problem, this point we should always highlight. As sir has asked,
Definitely,
tell about
definitely.
the symptoms of worsening or improving.
Yes, the symptoms of worsening.
Frequency of fall was increasing in nature, ma'am.
So
Frequency increased.
this was not
Untreated,
coming
the
up
child
from.
was worsening. Okay, yes.
So this was not coming up. Therefore, we had to ask this whether it is worsening or not. So it should come up that initially, if there is a fall, then initially the fall would happen when the child is walking down the stairs or walking on uneven surfaces. Then the frequency increased such that even when walking on a smooth surface, the child would have a fall. While walking for even for a minute or for 10 meters or 20 meters, there is a fall. So then the examiner would know, okay, These falls are increasing in severity. So these falls, if you say that fall is happening, then you have to tell me also whether these falls are associated with any injury that is happening. Is there any banging of head that happens? Because he has been falling around for 1.5 months.
There were injuries, sir. Those are not significant, sir. Only abrasions
So
of the hand and.
Can you tell me, if someone is having so many frequent falls, what possibilities should come to your mind? If that was the only history, if you saw the child in the initial 5 days itself, what should come to your mind? If someone is falling recurrently, then what are the possible areas on the brain or the spinal cord or the whole of the central nervous system is likely a reason for these?
Cerebellar causes, GBS, myopathies.
Good. So the answers is right, but it is always good to start in a sequence. So if I start from the brain, the first thing I would say that recurrent falls happening, I would think of whether it is seizures,
Cerebral cortex.
cortex involvement. So I will
Cortex
think of
involvement.
seizures. Then I would think of cerebellar involvement, that whether these are ataxias happening, which are associated with these falls. Now then I'll think of any extrapyramidal involvement, which has led to these falls. I'll think of a pyramidal involvement, which has led to these falls. Then I will think of a lower motor neuron involvement, where I'll think of neuropathy, myopathy, everything, all of these can lead to fall. So fall is a very vague complaint, and possibly this fall must have a reason here, because as a dictum, extrapyramidal involvement does not lead to falls, especially at the onset, unless and until it is very severe and has reached to a state of chorea paralytica or chorea mollis, if it is chorea. Or if it is dystonia, then it is so disabling that there is so much of twisting happening in the lower limb that the child is not able to stand. So generally, we don't consider fall as an initial presentation of an extrapyramidal basal ganglia disorder. If it is present, then you have to think, is there something else also happening? And the way this is appearing, it appears that there can be some myoclonus also, because you have described it as jerky, isn't it? So we have to remember what we are talking about. So sometimes if things are not very clear, we need to restrict the description of that, unless and until your examination or further questioning from the parents give you a more clearer picture.
Okay.
I hope I have
You
made
can
my
proceed.
point clear.
Yes, please proceed.
So
Deepa Lakshmi, you can proceed with the case sheet.
we can proceed with the case. Yes, ma'am.
Deepa Lakshmi, you have muted yourself.
I think he has lost the
Connectivity, yeah?
connectivity. I think he may join shortly.
Sir, host case sheet இருக்கா அவங்க டிஸ்ப்ளே பண்ணலாம் சார், அவங்க கூட பேசிக்கலாம்.
I think Ramesh sir has also written a couple of questions, and all of them are very valid. So once the students join, they should answer these questions.
Network disconnected போல இருக்கு. They are coming on another network.
கேஸ் ஷீட் வந்து நம்ம ஹோஸ்ட் வச்சிருந்தாங்கன்னா அவங்க டிஸ்ப்ளே பண்ண சொல்லிடுவோம் சார், so that
Yeah, just now he's joining.
joining. Yes, he has joined, sir. Yes. Yeah, no problem.
Screen share
You can share your slide, please.
Sorry for the.
It's
problem,
perfectly
no
okay.
problem.
It's perfectly okay.
Issues,
Just
one
share
or
your
two
slides again.
Proceed with your case sheet, Deep Lakshman.
Share
need
your
to-
slide, share your slide, please.
Yes, sir.
Screen share.
Yes, sir.
Share screen பண்ணுங்க.
Yes,
Yes,
ma'am.
ma'am.
Is the slides visible, ma'am?
Yes, very good. We are able to see your slides. Yes. You are the 5th slide. Yes.
Yes, ma'am.
இதுக்கு போய்க்கோங்க. ஸ்லைட் ஷோ போய்க்கிறீங்களா?
Yes,
Slide show போங்க.
Okay, good. Yeah, we are able to see you.
Next slide, pa.
Yes.
Next slide.
Because of this increase in severity of normal movements, the child became dependent on parents for his day-to-day activities like feeding. After 2 days, mother noticed speech disturbance, which she was not able to understand what the child is speaking. There was also history of emotional outbursts, which is in the form of crying and showing anger towards the mother whenever he tries to do any activity because of
Involuntary.
Okay. Once here we'll stop. Now you said child had even feeding difficulty. What was the type of feeding difficulty exactly?
Is not able to take the food
By his own.
on his own.
Okay, whenever he takes the food, what happens?
Spills
Because of involuntary movements and spilling over.
Okay. That was and speech disturbance. Could not understand what the child is speaking. What was the type of speech? Was it slurring? Or there is no output of words was not there? What was the type of speech disturbance?
slurring speech.
Child had a slurring speech. And or he was just making some unintelligible words and noise alone was coming and he was not able to speak at all.
Sometimes he is making noises, ma'am.
Unintelligible noises he was
Occasionally, he can able to communicate with his mother, ma'am. Only few words
Okay. So child had a
Whenever
slurring
the
speech and he was
involving face.
unintelligible words. I was not able to take his hands to the mouth and feed. That was the type of feeding difficulty. He was able to swallow.
Yes, ma'am. There was no difficulty in swallowing.
There is no difficulty in swallowing. There is no history of aspiration. It was just not able to reach to his mouth because of the movement. Okay.
Yes, ma'am.
Yes.
Shall I go to the next slide?
Yes.
For these complaints, they consulted a private hospital where they were given some drugs, which they took for 1 week, and then the symptoms of the child improved. But the parents stopped the medication on their own. After stopping drugs, the child again developed same movements with increased frequency and severity, ma'am.
Okay.
Shall I go to?
Yeah, no, wait. The child was given some drugs. What is the nature of the drugs which was given? Did you ask anything about for 1 week? Tablets or injections?
Tablets.
They have stopped the drug. That means, was there any total disappearance of movements for them to stop the drug itself?
Child was improved.
Mother, that is what mother telling, ma'am. There is a complete disappearance of movements.
All the symptoms. Do you think that what was the type of drug they took?
Tablet form.
Tablet form. How many
Tablets.
times? Small tablets.
Two times.
They have taken 2 times. Small tablets. Because what they have given, did you try to find out, or do they have any prescription of what was given, which made the movements disappear totally? Because anyhow, the course of the illness is going to be for months. Sometime it will last for a long period. So, what magic drug they gave, which made the disease disappear within a week? You should have been because once after stopping, child has again developed the movements. So you also should have known the drug what they gave.
Haloperidol they have given, ma'am. Sodium valproate they have given.
Tetrabenazine.
They have given.
All three they have
given 3.
All three have given.
Okay, and all three were given.
All three along with the penicillin they have given.
Okay, so they have correctly treated it. Okay, and the movements disappeared, but parents stopped and the child developed all the movements. Okay, yes. Okay. Proceed.
Yes.
But what do you think is the usual course of chorea? Do you think the whole thing will disappear within a week? Probably,
No,
What
ma'am, it was not reliable.
history?
Maybe
You
mother
need
was
to
Mother was
satisfied
very satisfied with the
decreasing in
Decreasing
frequency, she was satisfied.
No, I want to know whether after
It
giving
won't
her
disappear.
developed some new complication or side effect and she stopped, or because she
No.
stopped because the child improved. That also
She
you should
stopped. She told that the child improved, ma'am. So only they stopped that,
stop
not
that.
because of any complication.
So child has already been on haloperidol, sodium valproate, and tetrabenazine.
Tetrabenazine.
Okay, yes, I will talk about the treatment later, how these drugs acted on all that. For the time being, we'll proceed. Yes.
Yes.
Okay.
No history of abnormal eye movements, vertigo, dizziness. No history of stiffness of limbs, abnormal
What
posture.
do you mean?
No history of altered
Dizziness?
sensorium.
Wait, Lakshman. Abnormal eye movements, vertigo, dizziness, all together. What is it ruling out? What is
Cerebellar
what-
symptoms. Cerebellar symptoms. Nystagmus.
Nystagmus. Okay,
Vestibular.
yes. Okay, yes. Next, what are you
And
asking?
then stiffness of limbs, abnormal posture in
For dystonia.
dystonia.
Abnormal
and stuff.
posture, child was developing some abnormal posture only, no work. It was not persistent. That's what you mean. There is no abnormal
It was
posture.
not persistent, ma'am. It was
Like what posture you are looking for, which you are telling that is it's not there.
any dystonia. The child will, in case of abnormal dystonia.
Very good. Yeah, right answer. You thought whether there was a dystonia you meant. Okay,
Dystonia.
yes.
And then
Okay,
no history of altered sensorium, seizures. No history of skin rashes or
seizures,
malady.
altered sensorium, seizures, altered sensorium, involuntary movements. What did you have in your mind?
Autoimmune encephalitis, ADEM.
Excellent. Autoimmune encephalitis இருக்கலாம் இல்ல post encephalitic sequelae
Post encephalitic sequelae.
Okay, very good, very good. Yes, next.
No history of skin rashes or malar rash. No
Why
history of
did the male
headache.
child, why did you look for skin rashes, malar rash? You wanted to rule out?
SLE.
SLE.
Okay. Okay, SLE. So Chorea is also rare in male children, uncommon in male children, and again your connective tissue also. But
SLE also.
not in first rule, it's not, but still it's unlikely. Okay, skin rashes and skin rash were a malar rash. What are the skin rash? Malar rash. What? Okay.
Any viral fever. Viral fever.
Viral exam.
Viral
Exanthematous.
exanthematous.
Okay.
Skin rashes like erythema marginatum in case of rheumatic.
We are dark skinned individuals or fair skinned individuals. Have you ever
Dark.
seen an erythema marginatum in your lifetime? 25 years
No.
of practice, I have not seen one case of erythema marginatum, and you are dragging me to rheumatic fever. That's a good, that's a very good sign of, that's a very nice thing only. Where did you look for this erythema marginatum?
Over the trunk.
Trunk.
Marginatum in a case of rheumatic fever.
Trunk.
Trunk and.
Trunk, okay, site is right. But how many percentage of children with rheumatic fever will have erythema marginatum?
Less than 1%.
1%.
That you searched for erythema marginatum in that child. Okay, I accept your malar rash for SLE, but erythema marginatum is very unlikely. It is uncommon, and we will never be able to make. Very difficult to make out in dark skin individuals. Okay, very good. Proceed.
No history of headache, blurring of vision.
Okay.
No history of viral exanthematous fever. No history of loose stools. No history of any trauma. No history of any. For GBS. For GBS. Syndrome. Guillain-Barré syndrome.
I understand. But loose stools, what organism which can produce GBS? What is the
Campylobacter.
commonest?
GBS
can produce can follow Campylobacter.
Yes,
Okay, rumba far-fetched. Okay, why you haven't asked for more common complaints? For example, rheumatic disease, why you didn't ask for other complaints related to rheumatic heart disease?
First we are asking for etiology, and then specific for rheumatic complaints. Next slide, ma'am.
Okay, go back. Maybe this could have come earlier, and then you could have gone for etiology. Okay, yes.
Okay,
okay, yes, no history of yes, no, but doesn't matter. So Ramesh sir has asked, he's coming, sir. He's coming in the next slide. Ramesh sir, our அடுத்த slide la varar. Okay, next, what did you ask? No history of, yes, proceed.
No
proceed.
history of trauma, no history of any drug intake before the onset of symptoms, no history
What
of
drug-
jaundice.
For these symptoms, what specific drugs you asked? For example, what are the drugs which can produce movements like this?
Phenytoin, sodium alpine.
Phenytoin, very good.
carbamazepine,
Accepted. Do we use phenytoin commonly? Still in government hospitals, we do use phenytoin. Okay.
phenytoin.
Phenytoin can produce, is very good. Any other common drugs which can produce such movements? Yes.
Sodium alpine, carbamazepine.
Okay. drugs which-
Dopamine blocking drugs.
Dopamine
Withdrawal of dopamine blocking drugs, ma'am.
Okay. Okay.
What are symptoms?
Steroids.
Steroids can produce
Sir.
involuntary movements. Yes. So you want to tell that steroids are the treatment as well as the causative cause for chorea. Okay. Yes. Phenytoin I accept, sir. Any other drug which commonly produces involuntary movements?
Amphetamine, methylphenidate.
Amphetamine. Why are you nama children amphetamine edukra kumbala? And it is. நீ காமனா EPS கண்டிஷன்ல பாப்பேங்க ஒரு வாமிட்டிங் ஒரு காமனா பெரிஃபரல் எல்லாம் வாட் ட்ரக்
Metoclopramide.
I mean metoclopramide now we have stopped. Can domperidone produce extrapyramidal?
Domperidone doesn't produce
that much as metoclopramide, and metoclopramide we are no longer using. So one drug which you have told me which can produce movements are phenytoin, which is commonly used in children's period. Okay, yes, the next. No history of
jaundice, bleeding manifestation, no history of jaundice
Wait. Why did you ask jaundice bleeding manifestation?
or Wilson's.
Wilson disease, liver.
Okay. Okay. Wilson's, you asked jaundice and bleeding manifestation. Bleeding manifestation is a component of decompensated liver disease. So you mean to say child has developed Wilson's and gone for DCLD? No. Okay, now I ask one easy question.
Failure we are asking.
What are all the various presentations of Wilson's? And what is the age of this child?
7 years.
In 7 years, when does neurological Wilson's usually manifest?
After 10 years.
After 10 years, it's a
10
7
years.
years old child. So you have asked for hepatic symptoms. What are the various ways in which Wilson's can manifest?
Neuro regression can present.
Now 10 years if you are talking about hepatic Wilson's na enalla form la manifest pannalam. What are all the various
Fulminant
forms?
hepatic failure.
Fulminant hepatic failure.
Yes.
Signs of liver cell failure.
Jaundice
Hepatic failure, liver cell failure ella undada alla mottama vachiten nan aduthathu asymptomatic
asymptomatic
acute hepatitis ah irukkalama, chronic hepatitis ah irukkalam. It can be decompensated liver disease.
Decompensated liver disease also.
Again, it can present with fulminant hepatitis. These are the various manifestations of Wilson's. Very good. Next, proceed.
No history of poor scholastic performance, no history of developmental delay.
Poor scholastic performance, which disease?
Wilson's.
Again, Wilson's. Okay. No history of developmental delay. It's a regular school going child. This must have been the first sentence. Developmentally normal child, school going child. Okay, sir. Prashant sir, any question? You would like to ask them something?
I'd like them to complete this, then I'll.
Yeah, yes, proceed. Next.
No history of sore throat, no history of joint pain.
Why did you ask for history of sore throat?
Acute rheumatic fever, post-traumatic sequelae, streptococcal infection.
What is the relationship between sore throat and chorea?
Usually there won't during the manifestation of chorea there won't be any sore throat.
Okay.
But history is
chronic manifestation. Yes.
chronic manifestation.
இது அந்த எப்படி கனெக்ட் பண்றீங்க சோர் த்ரோட்டையும் கொரியாவும்? சோர் த்ரோட் வந்து ருமேட்டிக் ஃபீவர் வரலாம், பட் ஆனா this is the neurological problem. What is it?
Molecular mimicry.
Excellent. Molecular mimicry against which antigen or which neuronal process? Which against which part?
N-acetyl glucosamine part of bacteria against the tubulin.
Very good. N-glucosamine and
lysoganglioside.
Molecular mimicry against tubulin and your
Lysoganglioside.
ரொம்ப simple. As a pediatrician, we are all not going to become neurologists. Anyhow, when do you call it as sore throat and treatment of sore throat? This is a mandatory question for you.
Yes, ma'am. Sore throat, fever, and then
Posterior pharyngeal congestion.
posterior pharyngeal congestion,
Cell
and then
exudate.
exudates,
Transfer exudates in
Trans-
cell.
dysphagia,
Difficulty.
Dysphagia and diphtheria நினைச்சிட போறாங்க. Adenitis you will have to have.
adenitis.
Cervical.
Treatment. What is the drug of choice? What is the organism which produces sore throat commonly? Which
Streptococcus.
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 alpha hemolytica. ஒரு question வச்சு நிறைய கேள்வி
Group
இருக்க கூடாது.
Group A,
Group A,
beta
beta
hemolytic
hemolytic streptococcus.
Okay. Group A, beta hemolytic
Beta
streptococcus.
hemolytic
Okay.
streptococcus.
What is the drug of choice and duration of treatment for sore throat?
Penicillin,
Penicillin.
ma'am, 250 mg QAD for 10 days, ma'am.
Okay, but are we using penicillin that commonly nowadays? What are you
No,
using?
Amoxicillin.
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 Correct. Yes, very good. You can also, we are also using we are commonly
Amoxicillin.
the one thing which you rightly said was duration is 10 days.
10 days.
Even in pneumonia, the duration of antibiotic is 5 days, whereas in
5 to
for your sore throat, it is for 10 days. Very good.
10 days.
Excellent.
10 days.
And you clearly pointed out it was due to sir, as Ramesh sir is asking, what are the rheumatogenic strains?
1, 3,
5, and 12, 18, 24.
20.
Okay, very good. And you rightly pointed out about the molecular mimicry against your against
Neurons.
antigen also you have pointed out. Very good. Next point.
No issue of joint pain, fever, skin nodules, rashes, no issue of breathlessness.
All these
the,
are part of rheumatic
paroxysmal
fever.
knock-
You have asked
Rheumatic.
this is part of rheumatic fever.
Yes, ma'am.
Yes, ma'am.
Okay.
For
Joint
rheumatic
pain,
fever.
You asked for how exactly did you ask for joint pain in this type?
Whether it was involving lower joints, migratory in nature, whether involving and then improvement with any drugs, improvement with aspirin, salicylates, drastic improvement with the
The
aspirin,
pain was
salicylates,
severe.
severe excruciating pain.
With
What
no
is the new
residual.
criteria for rheumatic fever? New latest criteria regarding joint pain. You want polyarthritis, you want polyarthralgia or monoarthritis to call it as a major criteria.
Depends upon the area of involvement. Low
Okay,
risk
what
area.
you are in India. Okay, you are நீங்க அமெரிக்கால நம்ம இல்ல நம்ம இந்தியால இருக்கோம். இந்தியால என்ன criteria வேணும் உங்களுக்கு?
Ma'am,
What
They are
criteria
in
you
high
want?
risk.
You want
polyarthritis.
major criteria. What is your
Polyarthritis.
major criteria?
Major criteria: polyarthritis, polyarthralgia, and monoarthritis
Monoarthritis.
in major criteria, ma'am.
Monoarthritis can be taken as major criteria?
Yes, ma'am.
Yes, ma'am.
Yes, very good. That is what is expected. Okay. Polyarthralgia can be taken as major criteria?
Yes, ma'am.
Yes.
Can be
Polyarthralgia can be taken as
Yes,
major.
Okay, very good. Proceed. Yes, then?
No issue of breathlessness, paroxysmal nocturnal dyspnea, orthopnea, no issue of chest pain, palpitation, syncope, no issue of effort intolerance and fatigue, no issue of swelling of legs, no issue of abdomen pain, abdomen distension, no issue of decreased urine output.
So as per your history, what are you trying to tell us? There is no
The child
cardiac,
is not cardiac involved, cardiac.
No carditis.
no,
Cardiac speeches, cardiac failure speeches.
okay, there is no evidence of cardiac involvement, nor evidence of congestive cardiac failure,
Congestive cardiac
nor
failure.
evidence of carditis. That is your statement according to your history. Okay, very good. Proceed. Next slide.
No issue of visual disturbances, no issue of angle of deviation of move, no issue of drooling of saliva, no issue of difficulty in closing both the eyelids, no issue of difficulty in swallowing, no history suggestive of other cranial involvement.
Okay. you have
No
completed.
issue of difficulty in lifting head above the bed, no issue of difficulty in turning side to side in bed, no issue difficulty in perceiving sensation of clothes, hot and cold sensation and pain sensation, no issue of any bladder and bowel involved disturbance, no issue of sweating and flushing of skin. Next slide.
Slide.
Past history.
That's- Okay. So, sir, you want to ask anything? No? Prashant, sir?
Yes, ma'am. So just one thing that I would like all of you MDs know, that the purpose of negative history is two things. First, you trying to localize the problem on the neuro axis. So you want to rule out certain things that these are not involved and this is the only thing that is present. And the other thing is to get negative history about various etiologies. So what you have done is that you have clubbed both of them together. So you should ask that whether other problems are present or not, and you finish it up, and then you start for your etiologies. And because rheumatic is one strong etiology, then you should start with rheumatology, rheumatic diseases, all the history suggestive of a rheumatic fever first, and then you go for other etiologies also. So when we have these movement disorders, they generally don't present in isolation. Majority of time they come in combination. So we have to know that what one sentence I would ask so that I can rule out another movement disorder. So there is a characteristics one liner for all these movement disorders that we have. So if you go back to your first negative history slide.
Abnormal.
Okay. So this first sentence that you used, you said that you have used it for cerebellar disorders.
Cerebral.
So now we need to understand that cerebellar disorders cause incoordination. So that has to be evident from here. Now this child is not bedbound. So we'll have all signs of there. So we'll say that there is no history of any abnormal eye movement. There is no history of wobbliness. There is no history of titubation, swaying present. There is no history of difficulty in taking turns while walking. And the walk is like, there is no history of a drunken gait. So this is the thing that will rule out a cerebellar affection, which might be present if there is a particular entity. Now the second sentence is of what?
For extrapyramidal symptom,
Dystonia.
dystonia, for dystonia.
Okay, so what is dystonia?
Involuntary movement and sustained contraction leading to posture.
So you are perfectly right. I just want to revise it further or modify it to some extent. The dystonia is a sustained bizarre posturing.
Yes, sir.
We need to just ask that, is there any history of twisting, abnormal, bizarre postures which are sustained in nature? So this twisting, abnormal and bizarre, these three words have to come in, then only we will say, because what you are taking, abnormal posture, as ma'am has already pointed out, that it is actually there. He is attaining abnormal postures, though it is not sustained. And stiffening of limbs can suggest spasticity also. So this needs to be there. So can you tell me what other movement disorders are there which can exist along with chorea? So we have talked about chorea, we have talked about dystonia. What is athetosis?
Writhing movement.
Slow writing movements involving distal fingers.
So they can
Distal part of the limb.
so there can be etiologies where chorea can occur along with your
With
breathing
athetosis.
movement. So you can use that also, that there is no history of small amplitude breathing movements of the distal limbs or of hands. What else can be there?
Balism, sir.
Yes.
Large amplitude flinging type of movements, sir, which involving trunk and proximal joints.
Okay, good, very good.
That
So
can
this,
occur with chorea.
so generally this bellismus is hemi in nature. Most of the time you will see that it is unilateral. So we can say that there is no history of large amplitude proximal movement. Even chorea is large amplitude, but these are distal movements.
Proximal.
Okay. So hemibilismus is a proximal movement. So that is not there. What else? What can else be there?
So you finish chorea, athetosis, dystonia, hemibalismus. Any other involuntary movement?
Tics.
Okay.
Any other T? Any other T?
Tremors.
Very good. Okay.
Okay.
What sir is telling, are you able to understand, Deepa Lakshman? We are talking about neurological problem. Suddenly you are bringing in skin rashes and malar rash.
Okay, ma'am.
Or movement you suddenly brought
And-
skin rashes and malar rash. You are disconnected from your CNS. That's what sir is trying to tell you. So come in that one order. Okay, but you have mentioned all the movements, right? Very good. Tics, tremors, that also you have mentioned. Okay. Yes. Okay, proceed.
So have you summarized whatever the findings are there?
He'll be doing it at the end, sir. He'll be doing it. No, go back.
Okay.
Past no history of similar complaints in the past. Now,
have you heard of recurrent chorea?
Yes, ma'am.
Recurrent chorea indicates what? You are talking about similar complaint in the past is chorea. Now we know it's probably chorea. So recurrent chorea, what is the probability? What is the probability? How
In
common?
rheumatic,
20%.
20%.
20%. In
Can
rheumatic
have
chorea.
recurrent chorea. Recurrent chorea indicates what?
Subclinical GAS infection
Very good.
or
Commonest cause of recurrent chorea in our setup is recurrent GAS infection. Recurrent streptococcal infection, which can produce, okay? Otherwise, supposing this child has had a second episode of chorea again, then if it is not GAS infection, if you feel, what else can be the cause of recurrent chorea?
autoimmune causes, and then any mitochondrial
Very
disorders.
good. Autoimmune encephalitis, you mean? Autoimmune encephalitis can produce recurrent chorea. One very good.
Yes.
Yes.
SLE.
Other inflammatory conditions can also produce recurrent chorea.
Recurrent.
Okay. Recurrent chorea can be caused by recurrent streptococcal infections or autoimmune encephalitis or other inflammatory conditions. Okay. Yes. Next. Not a known case.
Not a known case of congenital heart disease, tuberculosis, bronchial asthma. There was no history of previous admission to the hospital.
Okay.
Antenatal history, the mother is booked an immunized case. All the trimesters were uneventful. In the natal history, the child cried at birth. There was no history of birth asphyxia. In postnatal history, there is no NSU admission.
One second, Srinivasan sir has joined, I think. Sir, good evening, Srinivasan sir. Sir? Okay, you proceed.
Good evening.
Good evening. Yeah, I was there outside. Yeah.
Okay,
Just
sir.
got
Sorry,
the
sir.
this
Good
thing.
evening, sir.
Okay,
Good evening.
listening to your this thing questions.
Good
Okay,
evening,
sir.
sir. Good evening.
Good evening. Good evening.
We saw you just now.
No,
Okay, sir.
yeah,
Good
I
evening,
came
sir.
in. I was not in the panel. I
Okay,
was
sir.
on the other outside. Then of course I was inducted. Thank you.
Thank you.
not playing captain, sir.
Ramesh sir was okay, sir. Thank you, sir. Thank you. Proceed.
Postnatal history, there was no history of no history of NSU admission and no history of neonatal jaundice and neonatal seizures.
Okay.
Developmental history, the developmental milestones for appropriate for age.
One second. 1 minute. Developmental milestones appropriate. Here you should have mentioned whether this child is attending regular school, which standard, and is there a period of school absenteeism at present. Now appropriate for age, you tell, is the child school going?
Yes, ma'am.
Yes, ma'am.
7 years old. Which standard the child is in?
Second standard.
Standard. It's a any scholastic performance is good.
Good, ma'am.
The child is having prolonged school absenteeism.
Only this.
No, ma'am. No prolonged
No,
absence.
no, school absenteeism.
There is no history of any prolonged school absenteeism.
No,
Regular
no.
school going child performing well. Okay.
Well,
Yes. It's important to know about all this. Is there any history of school absenteeism, not going to school for quite some time because of the illness?
Most performs Wilson's and then
intellectual
intellectual
disability
disability.
in inherited disorders.
And
Okay,
then
and if it is
it
going to
indicates a crown.
Ramesh sir is clearly asking whether there is any deterioration in handwriting. Did the handwriting become very small? Was there any micrographia? Sir is asking. நீ கேட்டீங்களா இந்த ஸ்கூல் பத்தி நீங்க கேட்கல. From your looks, I feel that you haven't asked about the school. Did you ask anything about the school
Very
absenteeism?
important question. Micrographia and
Yes,
micrographia.
micrographia.
Where you
The
get
hand-
micrographia? Where you get micrographia?
Yes.
Micrographia in cerebellar involvement, micrographia, sir. Macrographia in Wilson's poor handwriting.
And another thing you usually ask is when they go to school, where they're fighting with the peers because of this emotional problem. Was there any problem in the school like that? Did you ask any history?
Yeah, it's the other way. Yeah.
Yeah, ma'am.
So cerebellar, because of ataxia, the words become bigger and bigger, and micrographia because of the paucity of hand movements, So increased tone, there will be becoming micrographia. Am I correct, Jauhari and madam?
Yes, sir, you are
Yeah.
head on. Yes, sir. There would be abnormal strokes that would be there because of this ataxia. So if you make them make a spiral, they will not be able to make it, and you will see that the movement, the strokes are going laterally to the perpendicular to the movement which it should actually be there.
And usually
That
ask
is
the
there.
child to draw a star also, twice,
It won't
five
be
corners.
there. So any deterioration handwriting, was it able to write something? Did you ask Deepalakshman?
There was during the illness, during this 1.5 months, the child was not able to write, no, but before there was no complaints of handwriting changes.
For the past
any
1.5
changes in
months,
handwriting.
child is not attending school.
Yes, ma'am. For the past 1.5 months, the child was not attending school.
You should have mentioned that school absenteeism for the past 2 months.
Yes,
I
ma'am.
mentioned because now we know it's a chronic illness. That 2 months are pogala school mukkiyamaana vishayam. Okay, yes, proceed. Next. Yes.
Diet history, the child takes mixed diet. There is a calorie deficit, deficit of 584 kilocalories and protein deficit of 4 grams. Immunization history, the child is immunized till age. Last vaccination was at 5 years of age. There was no adverse effects following immunization.
Okay.
Family history, no history of heart disease in family, no history of sudden death in family members, no history of similar complaints in the family members.
Okay, yes, proceed.
Socioeconomic history, they live in a semi-pakka house, 4 members for 3 rooms. According to modified Kupsami scale, they belong to upper lower class.
What is it? PCA another 2000. What is it?
Per
PCA.
capita.
Okay. Okay, proceed.
Contact history, no history of contact with active case of tuberculosis and other infectious diseases.
What do you call it as household contact of tuberculosis? Whom do you call as household contact of tuberculosis? Evlo duration
Within 2 years, ma'am.
No, it was changed to 1 year.
Presence of
one question. This is apart. This is out of question. But still, what is the latest guideline as far as tuberculosis is concerned? For example, you have contact of tuberculosis. What is the guideline for them?
1 year. Now it's changed to 1 year.
It is yes, contact has changed to 1 year. And what do you do for these contacts? All which age group you want to give INH chemoprophylaxis? Mandatory question. Previously,
Less than 6.
Not less than 6 years for all children who are contact. Now you'll have to give INH chemoprophylaxis. And what are the various types? You should have this mandatory question. You should have known. Okay, next question. Yes.
Summary: 7 years old firstborn developmentally normal male child of 3rd-degree consanguineous marriage presented with frequent fall and abnormal movements involving all the 4 limbs, face and trunk, with emotional lability for past 1.5 months with no significant past and family history. My diagnosis is movement disorder, chorea. Probable etiology is rheumatic fever. I would like to proceed with CNS and CVS examination.
Okay, I accept you think in terms of chorea, but why did you think in terms of rheumatic fever? You didn't have even one reason to call it as rheumatic fever.
As per
emotional
the
lability and hypotonia.
Hypotonia.
Yes.
Frequent falls for hypotonia, involuntary movements and emotional lability for triad.
You are telling me that hypotonia, involuntary movement and emotional lability, all three are part and parcel of pseudonyms chorea, and it is also the commonest cause of chorea. You thought it was
children.
Am I right?
And also the sensorium. No, there is no history of altered sensorium. Seizures.
No rashes.
No.
So you're not thinking in terms of other causes. You're thinking in terms of rheumatic. As such, do you have any history for rheumatic fever in this child?
Ma'am?
No history
You call it as rheumatic fever. This child who is having chorea, can you call it as rheumatic fever? This is the only one sign for calling a child having rheumatic
with a single major criteria.
Yes, speak clear. Yes.
Yes,
For rheumatic, to call a child as having rheumatic fever, you should have 2 major criteria and one minor.
It is the exclusion for diagnosis. If there is chorea, means it is the only. It can be the only major criteria for diagnosis of rheumatic chorea.
That is what. Yes, chorea alone can be the major one criteria to call the child as rheumatic fever, and you are calling it as rheumatic chorea because you have that triad of triad.
Hypotonia, involuntary movements, and emotional lability.
So you are having the triad, so you want to call it as rheumatic chorea. Okay, yes, sir. Prashant, sir.
Thank you, ma'am. So So you have summarized it quite well, but still I have a few questions here for you. So what is chorea, if you want to tell me? What is chorea?
Describe.
Rapid involuntary semi-purposeful movement.
Yes.
Non-repetitive movement.
Non-repetitive.
Flowing
Okay.
from one part of the body to another
Okay,
part of the body.
rightly said. So
Yes, during
it is random, non-repetitive,
purpose.
flowing movement, which is transiently or quasi-purposive in nature. If you know that this is there, then this should have come in your summary. If you don't write this in your summary, how will you say that just by history of frequent fall and abnormal movements, how will you conclude that this is chorea? So all this information that you are giving us, it should be there in your summary. That is the purpose of summarizing. Now, if you say in your summary that there is hypotonia present, this is nowhere to be seen. And on your history, you will not be able to make out unless you do an examination. So that point will not be as certain on your history. So in history, what you have is there are frequent falls. Now it is not just reducing the number of words and coming up. Now you have to make an analysis also of this summary that you have given. So your summary says that there is frequent falls and abnormal movements. Then it opens the gate for all abnormal extrapyramidal or cerebellar involvement that could have been a possibility. So the summary is definitely an art. If you make a good summary, it means that you have understood the case well. So the summary you have to actually revise. So you have to present all these features that you have told me here.
Yes, sir.
Okay. And then sometimes even a negative, a thing which is not there in you didn't find on examination, that also becomes important.
Yes, sir.
Here, absence of other movement disorders and cognition being intact is one important feature. So the cognition is there because the child is developmentally normal, you said, going to school. And then the summary also should tell me what is the severity. Now, I want to plan treatment. So how will I plan treatment unless and until I know from your summary, if it is possible, that what is the severity of that problem? Is it a mild case? Is it a moderate case? Is it a severe case?
That is very important.
So that can be made up with your history. You don't need an examination. This was there in your history, in fact.
Yes, sir.
So that should have been here in your summary.
Yes, sir.
What sir is telling us, you should have described that abnormal movement. Here in the summary, you have written abnormal movements. No, in that place, you should have written what is the type of movement. What all you described about chorea, you should have made out. And that frequent falls, that was probably due to hypotonia, that you should have added it up. And again, as sir rightly pointed out, you should have told us whether it is a mild, moderate, or severe form of involvement. The involuntary movements were mild, moderate, or severe. You should have mentioned. It's very important for therapeutic purposes also. Okay.
Yes,
and the course of disease also, how it is going to be, is important. And still, you can now tell us whether you feel it is a mild chorea, moderate form of chorea, or severe form of involuntary movement.
Severe form of.
Why do you say severe form of chorea?
The child needs
day-to-day
day-to-day
activities,
activities.
Day-to-day
The child
activities.
depends on the parents.
Day-to-day activity.
Day-to-day activity, interrupted day-to-day activities of life. Child was not able to eat. Child was not able to walk. Child was not able to move. Child was falling and it was not moving around. So it totally interrupted. Was the child bedridden? It was sitting constantly.
The child tries to walk, ma'am, but whenever he falls.
Okay, so as per your history, child has got a severe form of involvement. Okay, yes, proceed. Now we have another 20 minutes or 25 minutes. You'll have to tell us about two systems. Probably you can proceed earlier, fast. Yes.
General examination, the child is conscious, oriented, afebrile, no pallor, icterus clubbing, cyanosis, head to foot examination, head size is normal, no facial dysmorphism, no malar rash, no cave-free proptosis, eyelid retraction, telangiectasia, oral cavity, dental gaps present.
1 minute. Cave-free, I can understand. This you asked it for to rule out.
Wilson's disease.
Wilson's disease. Okay, yes. Proptosis, for what did you ask this for?
Hyperthyroidism.
Oh, one of the
Metabolic
other
causes of
other
chorea.
causes of chorea.
Causes of chorea.
Metabolic causes of
Metabolic
chorea
causes of chorea.
or endocrine causes of chorea.
Endocrine.
You ask for proptosis. Okay, eyelid retraction for.
Hyperthyroidism.
Okay, what are the endocrine causes which can produce chorea then? You tell me then.
Hyperthyroidism, hypoparathyroidism.
Hypoparathyroidism.
For these two reasons you have asked. Okay.
Yes.
Then telangiectasia, why did you ask?
Ataxia, telangiectasia can associate
Can be one of the genetic causes of
Genetic causes of chorea.
நிறைய club பண்ணிட்டீங்க எல்லா ஒரே you have clubbed different things together. Okay, yes, அடுத்தது dental caries is present. Okay, yes, next proceed.
Yes, throat extremity is normal. No spider nevus, palmar erythema, xanthoma. No skin nodules.
இதெல்லாம் எது கேட்டீங்க? Why did you ask for spider nevus, palmar erythema, xanthoma?
Signs of liver failure.
Liver cell failure.
Wilson's.
Which could have occurred in Wilson's.
Wilson.
ரொம்ப far-fetched இருக்குடா. And again, all these peripheral signs of liver failure are very, very uncommon in children. Have you ever seen a spider nevus or palmar erythema in a child with the decompensated liver disease? The only finding you will see for decompensated liver disease, a peripheral sign in child another. Have you ever seen a spider nevus in child? Very, very rare. Very, very rare. They are more common in alcoholic liver disease, which occurs in adults. As far as liver disease is concerned in children, the only peripheral sign of DCLD which will come is dilated, enlarged veins over the upper abdominal wall. That is the only sign you might see. Okay, that's not maybe very not ரொம்ப needed negative still. Okay, leave it. Next, no skin nodule. Nodule for what?
Subcutaneous nodules.
Rheumatic fever.
Chronicity.
Okay, that is very important. Okay, but subcutaneous nodules, where did you look for in rheumatic fever?
Extensor aspect of the back, spinal process, nape of the neck, chin of tibia.
They are painful or painless?
Painless nodule.
What is the size of the nodule?
0.5 to 1 centimeter.
So very less than a size of a pea, very small ones. Presence of skin nodules in rheumatic fever indicates what?
Cardiac.
Active carditis. Indicates active carditis. There is no skin nodule. You already mentioned about erythema marginatum also. Very good. Fine, normal. Okay, yes.
Vitals. Pulse rate was 100 per minute, regular rhythm, normal volume, no specific character, no radial delay, no radiofemoral delay, felt equally in all peripheral vessels. Respiratory rate was 22 per minute, thoracoabdominal type, saturation was 99% in room air. BP in all the 4 limbs were normal, JVP was not elevated, capillary refill time was less than 2 seconds, pulses felt equally, and then temperature was afebrile. Child was afebrile.
In rheumatic fever, what is the new guideline for you to call that the child has got fever and it's a minor criteria?
Temperature more than 38 degrees Celsius in high risk population.
38.5 in
38.5 in low risk, 38 in high risk.
You were guided. Okay, very good. So you have learned the guidelines correctly. Very good. Yes.
Anthropometry, BMI, according to BMI, the child is underweight. In case of BMI, SMR stating the child
underweight சொல்லுவீங்களா? BMI எப்படி கிளாசிஃபை பண்ணும்போது நம்ம என்ன சொல்லுவோம்? This is
thinness.
இது வந்து the mandatory column னு சொல்லுவோம்ல, அதுல இது வரும். BMI அது you should tell whether it is thinness, severe thinness, normal, overweight or obese. You shouldn't, the inference shouldn't be like this. Okay, please change it. Next time you shouldn't write that. In the அஞ்சுல தான் ஏதாவது ஒன்னு சொல்லணும். You shouldn't call it as underweight. Okay, yes, next. Very good. That you have 7 years ஆனாலும் SMR பார்த்திருக்கேன். Very good. SMR you have seen. Very good. Yes, அடுத்தது next slide. Okay, that's qualify பண்ணிருக்கேன். Very good. Yes, அடுத்தது போங்க. Next slide.
CNS systemic examination, CNS. Higher function, the child was alert. Frequent crying was present. The speech of the child was not clear.
Frequent crying without any provocation. நீங்க அதை qualify பண்ணணும். அதாவது emotional ability, what you want to tell is child keeps on crying without any provocation. ஒண்ணுமே செய்யாமே child is crying. Okay, no provocation. Yes.
The speech of the child was not clear. The
pattern, you should tell us what is the type of speech. அது வந்து aphonia இருக்கா, slurring இருக்கா, what is the type of speech you should tell us. Yes. You want to tell me that it is slurring speech. Okay, yes.
Slurring of speech, and the sleep pattern is normal. The child is a right-handed child.
Yes, yes.
Cranial nerves examination, all the cranial nerves examination were normal.
Normal. Okay, sir. He need not tell in detail. No, he can proceed. Yes. Cranial nerve
Yes,
examination, you
yes,
didn't
ma'am.
make out any cranial nerve abnormality. Very good. Yes. Go ahead.
Spinal motor system, there was no obvious muscle weakness, wasting, muscle wasting, and then the tone was normal in all the 4 limbs.
You said
Power of the
hypotonia. You
child.
went on telling me it is hypotonia. On examination, you are not able to make out any hypotonia.
Yes,
Yes.
not on examination, not able to.
Or it has improved.
Child was continuously having abnormal movements.
The child was having
Continuous
Abnormal movements.
So since it was having abnormal movements, you couldn't assess the tone. Sir, can we accept it, Prashant, sir?
But still there should be an attempt. But anyway, these movements, that falls that were happening, they were not because of hypotonia. I told you before also that hypotonia will not have such a presentation. But anyway,
yes, sir.
you have to make an attempt to say whether the tone examination was so you can talk about posture, how the posture was there any increased flappability was there, whether there is restriction of movement to at any joint was there, or there were more movements happening. What was the amount of passive movement that could have been done? So all these ways we can have some subtle assessment whether tone was normal or hypotonic or hypertonic for that matter.
நீங்க spinal motor system சொல்லும் போதே ரமேஷ் சாரும் பாயிண்ட் அவுட் பண்ணிருக்காரு. Attitude of the limb. Whenever you do a CNS
the child was frequently changing
positions and movements, and there was no particular posture the child maintained.
Specific posture.
Okay, yes.
While sleeping, the child was comfortable.
Okay. Yes. And again, Annamali Vijayaraghavan sir is reiterating the point that you shouldn't use the terminology underweight in children more than 5 years. As I pointed out earlier, you shouldn't use the terminology underweight. As pediatricians, nutrition, anthropometry, immunization, see to it that you don't make any mistakes. Okay, that is very important. Okay, okay, proceed. Appallam.
Tone is normal.
Okay, tone is normal. Yes, both sides is normal. Next slide. Next slide. Go fast.
Power is 4/5 in all the joints.
Okay. Against resistance, you check.
Yeah, I asked him, but he was not able to do those.
Okay, okay. Next slide. Next slide.
Full strength, he is not able to
do it. Okay, okay. Proceed. Good.
Okay. Deep tendon reflexes normal.
Anything about deep tendon reflexes you particularly noted?
Hung up knee reflex.
Hung up knee reflex.
Hung up knee reflex.
No, that occurs in Korea. But this child have hung up reflexes?
No, ma'am. This child doesn't have hung up reflexes.
It didn't have hung up reflexes. What do you mean by hung up reflex?
There will be delay in the
relaxation.
Okay, very good. A sustained contraction or delayed
contraction.
Slow, but you couldn't make out anything of that sort in this child.
Yes, ma'am.
No.
There is no hung up reflexes, but reflexes.
No hung up reflex.
You are able to elicit normal reflexes. Okay, yes, go ahead.
Yes.
Did you perform any maneuvers in this child to make out all these abnormal movements?
Yes, ma'am. We have performed the
videos
are coming the last.
Later?
Yes, ma'am.
At
the last.
Okay. Deep tendon reflexes, you didn't make out any abnormalities. Superficial reflexes are normal. Next slide. Next slide.
Sensory system.
Sensations normal. Okay. Cortical sensation, 7-year-old boy, test, why could not be tested?
Because of movements.
What are the cortical
Not able to communicate.
What are the cortical sensations you tried?
Tactile localization.
2-point
discrimination.
7-year-old boy, can he not make out cortical sensations? Or pinadi or 8 போட்டீங்கன்னா 8 சொல்ல மாட்டானா?
Not able to communicate. Facial grimacing.
Oh, speech was abnormal.
Speech was abnormal.
Yes, okay, okay, okay. Yes, yes, yes.
The movement was involuntary, rapid jerking, non-repetitive, semi-purposeful movement which flows from joint to joint. It involves shoulder, arms, hands, face, legs, and trunk.
Okay.
This is the movement, ma'am.
So
according to USMG Sydenham Korea rating scale, it comes up to 56, ma'am.
Oh, okay.
This is the
Milkmaid grip.
Milkmaid grip, ma'am. The child is not able to maintain the grip,
Sustained
grip, ma'am.
Motor impersistence, we call it. There is no
Motor,
persistence of your grip.
Motor.
There is motor impersistence. Very good. Yes. Milkmaid grip.
Darting tongue, ma'am. The child is not able to keep out the tongue.
Okay. Good videos. Okay. Yes.
Pronator
sign.
sign, ma'am.
Oh, child is not even able to sit. Okay. Okay. Had a tough time. Okay. Yes.
Touchdown.
Good.
Then,
Good videos you have shown. Now, what are you trying to do?
Spooning self spells.
Okay. Yes.
Or he can spoon. That's it.
While sleeping.
Can you show the video, just
While sleeping.
the previous video, please?
Which one, sir?
This one only.
Okay.
This one.
Can you play it again?
We will play it again, pa.
Extension.
So what
Extension.
what happened? What happened here?
Falling forward.
So what was
Not
that?
able to maintain
Not
the
the child is hand hyperextension. Hand wrist
flexion with the
flexion and fingers
hyper-
extension, sir. Spooning of the hand.
But there was a sudden jerk that happened. The whole body went forward, and it was shock-like in nature. Repeat the video.
Does it look like myoclonus for you? Yes.
So if you look at then focus on the lower limbs also. They also move slightly. So it appeared that there was a sudden jerk that happened. So I'm not very sure, but then if repeated this is happening, and that is the reason for these falls. So then that has to be included.
Okay, sir.
Generally, ataxia will not be jerky in nature. And for chorea again, at some times it can take a jerky appearance,
Okay,
but mostly it is flowing movements
flowing movements.
that happens. So randomness, and then flowing in nature, and motor impersistence. These are the three key things that define chorea. But this was slightly, but I agree, I'm not very sure. But if it is occurring, if we can have separate videos and that shows that these are sudden jerks that are happening, then possibly this kid is also having these myoclonic events. Okay, go ahead.
Chorea
Disappears during sleep. Very good. Good videos you have taken. Very good.
Thank you.
And it is opened beautifully along with your case sheet. That is also a nice thing, because usually videos open a time waste of. It's very good. It has come as
I
part
also
of.
appreciate, madam.
Yes, sir.
Excellent videos and very well
taken.
illustrated.
That's a very good attempt and very common.
And it has opened nicely also. Thank you so much. Yes.
Cerebellar signs could not be tested. Gait could not be tested. Spine and cranium normal. Autonomous nervous system normal. Peripheral nerves normal. No signs of meningeal irritation.
Okay.
Other system examination. Cardiovascular system inspection. Chest wall appears normal. No visible pulsation. No engorged veins over the chest wall. No apical impulse seen in the left fifth intercostal space at midclavicular line. No surgical scars. On palpation, tracheal position is in midline. Apical impulse is felt in the fifth intercostal space at midclavicular line. No parasternal heave. No palpable heart sound. Palpable thrill. Auscultation. Mitral area. We heard S1 was soft. S2 heard normally. There was a pan-systolic murmur of grade 3, high-pitched, soft blowing murmur conducted to axilla, which was best heard when the patient is lying in left lateral position with the breath held in expiration with the diaphragm of the stethoscope. In other areas, murmur was
Okay. Okay. Other systems.
Other systems, abdomen and no soft, no organomegaly. Respiratory system was normal. Vesicular breath sound heard, no added sounds.
Okay.
Summary. 7 years old male child, firstborn child of third degree consanguineous marriage, presented with frequent fall, involuntary movements, which was semi-purposeful, rapid, involving all the four limbs, face, trunk, which was aggravated when he tries to do any work and disappears during sleep. It was also associated with emotional lability for past 1.5 months with no history of any drug intake, no significant past history and family history. Child is a developmentally normal child and underweight and had nutritionally severe thinness. On general examination, the child has positive pronator sign, darting tongue, spooning, milkmaid grip with normal intact sensation, sensorium, and no cranial nerve involvement, cranial nerve palsy. The child also had grade 3 pansystolic murmur in mitral area with no organomegaly. With this, the possible diagnosis is rheumatic chorea with mitral regurgitation with no signs of congestive heart failure or infective endocarditis with severe thinness.
Okay, good. Okay. So you feel it's a case of synonymous chorea, rheumatic chorea with mitral regurgitation with no congestive cardiac failure. Okay. Do you have this? You have any differentials?
Differential
Do you need
diagnosis?
any differentials?
No,
This
ma'am.
child
Here,
has got a heart disease and this child has got chorea. Do you need a differentials, Sir Prashant sir?
no, ma'am. No need.
We have two major
Two
criteria.
major criteria.
It's in the two major criteria.
Okay. So if you have anti-Rho, anti-La antibody associated lupus, so you can have cardiac involvement there. So are you aware?
Yes.
SLE, cardiac involvement.
Cardiac involvement.
Can MR occur in SLE?
So then that can be a possibility, isn't it?
MR.
Male child.
Sir?
Yeah. So so these would be the cons. So male, it is less common. Does it say that it will never occur?
Male child is not.
So these numbers, they don't count when you are dealing with an individual case. Something is present 70% times, something is present 10% times. This is better when you are answering a theoretical question in your answer sheet. But when you are dealing with an individual case, you have to go by what you have identified in your examination. And rheumatic chorea definitely would be the thing which would be the highest on the cards. That is well written. But then the other differential,
Right,
could
go to the
that
next
be
slide
a
also.
possibility?
He has written some differentials. Sir, go to the next slide. Yes.
Wilson, this is a drug-induced Huntington
Drug
chorea.
induced, what drug you said? No drug. So you can take that
No
from
drugs.
your differential.
Yes, ma'am.
Okay.
Yes, ma'am.
Wilson's, you thought in
Yeah,
terms, but
then
and heart disease,
means-
Wilson's disease, no. So
Yes,
the
ma'am.
Wilson's
Not.
not there. Huntington chorea you have made as a Huntington is disease of adults or can it occur in children too?
Adolescent age group.
Adolescent age group.
Can occur. Any specific manifestation you require in Huntington's chorea apart from an involuntary movements?
Rigidity, bradykinesia.
Westphal variant.
Yes.
Rigidity, okay. Bradykinesia,
Bradykinesia.
okay, other word.
Psycho.
Where anything more?
Psychosis.
Dementia.
Dementia.
Cognitive decline.
Dementia. That is
Dementia.
very form of dementia is very characteristic of Huntington. So it's
Huntington.
very rare in children, one of a differential.
Okay.
Sir, he has put
So-
SLE also as his differential.
Definitely. Just one thing maybe for everyone to understand it. In pediatric age group, Huntington doesn't present with chorea.
Yes.
So if for chorea in pediatrics, Huntington's is not a differential. In pediatrics, Huntington's present with the Westphal variant, which presents with dystonia. If you have a progressive dystonia, then Huntington's Westphal variant is a possibility. Otherwise, Huntington's chorea will not be a possibility here in this 7-year-old child. So, and for Wilson, neurological complaints sometimes can happen before 10 years also. So what we have seen that the hepatic decompensation starts at 3.5 years, and then after 2.5 years after that, copper spills over and the neurological complaints can start early.
Isolated chorea, probably you should have thought in terms of Wilson's also, because it's one of the most important treatable neurological problems. That is right. But when there's already a heart disease, probably you should
Then-
take up Wilson's and you should have kept SLE as a One of your differential.
Yes, ma'am.
Do you think this is a typical case of Sydenham's chorea, or it is an atypical case and you want to do further investigations? Do you want to do investigation for SLE in this child or not?
We can
First line
do.
you want to
Actually,
do
we
or
have
not?
You can
First
do.
line.
We have
No, first line you want to do or not?
First line.
First line you don't want to do. First line, what are the investigations you are going to do? Show me your slide. What are the first line investigations you are going to do for the child? Yes. First line,
CRP.
CBC,
Yes,
you have done nothing much. Okay, yes. Your CRP is negative. Very good.
Negative.
Negative.
ASO titer.
But did you expect your ASO to be positive?
No, ma'am.
How? Okay. But if you are allowed to do anti-DNASB, you would have done it, because which antibody stays longer? Chorea is a chronic manifestation. It takes a longer time. Maybe even after 6 months of your infection, you might have chorea. So if you are allowed, if you have the investigation, you would have preferred ASO or anti-DNSB.
Anti-DNS.
Anti-DNSB.
The anti-DNSB stays longer, but in this child, so ASO negative, does it rule out that this child never had streptococcal infection and developed chorea just like that?
Doesn't rule out.
It doesn't rule out a streptococcal infection. Your ESR CRP is negative. Again, this gives you some other clue that it may not be SLE also. Your
Yes,
acute
ma'am.
phase-
It cannot be SLE. Ma'am. It will be raised in SLE. Autoimmune disorders.
Okay, next, what are the investigations you did? RFT, LFT. Okay, சரி பண்ணிட்டேங்க LFT. Okay, yes, அடுத்தது. You want to do your anti-DNA double strand. You want to do investigations to rule out SLE in this child or not? You tell me.
Yes.
Here
is it a
typical case of
what is atypical about in this case?
typical murmur, cardiac involvement and chorea.
And
You didn't want to do a anti-DNA. It is not a recurrent case. It is not. It is a male. The only problem, I mean, it's not even a problem. Child is a male child. Child is having, but since the child is having chorea plus heart disease, you didn't want to investigate further. Only SLE you had in the back of your mind. Did you think in terms of doing APLA antibodies in this child, or NMDA, anti-NMDA you wanted to do, or anything like that you wanted to do in this child? No. You didn't want to do. Yeah, you may be right. Yes. You want to do or you didn't want to do? You don't want to do. Are you having a connectivity issue?
Yes, ma'am. I think it's freezed.
Yes.
Freezed.
Yeah, 5 minutes. Okay, they are going back. Come back another 5 minutes. That's it.
Devalakshmi, unmute pa.
Yes. Yes, come. Yes. Yeah. So you don't want to do Devalakshman. You don't want to rule out. You don't want to do NMDA, APLA, double stranded DNA antibodies. You want to do in this child, or you don't want to? No, madam, I don't want to do. Child is having carditis. Child has got congenital heart disease. Child is having. You don't want to do. You can tell me.
We can do, ma'am. Do.
You want to do or you don't want to do? I accept both.
No need pa. No need pa.
Okay. So you don't think it is a atypical case, so you don't want to do. That is your answer. Okay. Go back to your next slide. You have got all your acute phase reactants negative. Okay. Go back to your next slide. Next slide, Devalakshman.
Sir, connecting issues there, madam.
In over 2 minutes,
But I can ask question. I think you can. Yeah. Just.
Can you hear me, Devalakshman?
So I think until connectivity, Dr. Prasad, can you tell any comments, please?
Comments.
I think they have done quite a wonderful job in describing this case, though this was very simple, that straightforward, the diagnosis was straightforward, but yes, we were able to just identify what are the other things laterally that the thought process should go on. So I would just suggest that for residents, when you do this, you start with a broader approach and then you try to culminate. So just one thing as a simple comment, that once we see that the examination then gave us the diagnosis clearly that there was MR, there was systole murmur, which was present in the mitral region. If suppose that was not there, there was no signs of active carditis, then all these possibilities that you was discussed would have been wide open. So once you have
Can he can complete it, sir? He has come
Yes,
back.
yes.
Deep Lakshman, any
It's
other
there.
investigations have you done?
A&E it was negative, ma'am.
Okay. Yeah, you have done an A&E.
Yes, ma'am.
DNA was negative.
Okay, yes, okay, yes, because, okay, yes, you have done an A&E. A&E is negative. Next, what else you did?
Negative.
Anything else you have done?
Ma'am, echo
Echo you
showed
have
echo ECG, it was normal, ma'am.
And
And then
MRI
I
brain.
showed-
You did an MRI.
Yes.
Why? You have done an echo. Echo clearly shows mitral valves are thickened. Then why did you go ahead with an MRI? You needn't have done an MRI. What did you look at?
Avoiding future litigation.
No, sir. But anyhow, he had a classical case.
No, I was just
Having
joking.
taken that MRI, you tell me now what are the indications of MRI in a case of rheumatic chorea? In a case of
Not
chorea?
respond. And
Not respond. That is not an indication. Anything else?
ma'am.
To be more specific.
Recurrence, ma'am. Recurrence of chorea. Recurrent chorea.
Okay, one is hemichorias. Purely
Hemichorea.
hemichorias can sometimes we don't know, maybe a lesion in the brain. And another thing, when you are not able to make out any evidence of gas infection, streptococcal infection, evidence absence of any evidence of GAS infection you can do. And very atypical findings. But this child has got very typical findings. This is one case where you shouldn't have done an MRI. Okay,
Yes, ma'am.
that you needn't have done. But rest of the things are all okay. And if then what did you do with the child? What was the treatment you have given? You gave?
Ma'am, we continued the.
Okay, you have given. So see, that patient improved dramatically with sodium valproate. You told me.
Valproate.
You could have continued haloperidol. What made you give prednisolone?
Ma'am, even during the stay,
you should justify why you gave prednisolone. If you don't want to give also, you should justify whatever it is. Prednisolone is not the standard treatment guidelines of rheumatic fever. Prednisolone or treatment nobody mentions. Okay.
yes, ma'am.
In studies, they have mentioned that prednisolone can decrease. So what made you give prednisolone?
To decrease the duration of the treatment, ma'am, by giving prednisolone,
Improving with
not improving with classical.
No, how long did you wait for improvement to occur? Sodium valproate, haloperidol, tetrabenazine, all these three things you gave. How long did you wait for the treatment, for the condition to improve?
10 days, ma'am.
Very short, very, very short.
Yes, ma'am.
During that period,
2 to
what
3 weeks.
prompted you to give prednisolone? It was really very troublesome to the patient.
Severe-
The child was
severe
having
areas,
injuries,
ma'am.
ma'am. The child was having injuries.
Started getting into injuries. How do you think prednisolone can help? How long you are planning to give? You have given 2 milligram per kilogram per day. That is the maximum
Yes, ma'am.
dose. How long you are planning to give?
Ma'am, for two weeks, for 2 weeks and then tapering, ma'am.
Okay, you plan to give it for 2 weeks and taper, but actually
2
you can
mg
even give
for
up to
2
4
weeks
weeks.
and then taper the dose for another
Taper
2
the
weeks.
dose. You are planning for 4 weeks. Now, if I get another 2
Tapering.
weeks again. Okay, but starting steroids is it's a controversial. That is, so Nelson by itself says that you can give steroids if the symptoms are very severe, and definitely steroids, they reduce the course of illness or reduce the duration of symptoms. And for example, 2 months our disease 15 days or 3 weeks, it definitely gives better patient comfort. And you also said it's a severe form. So maybe you're justified, but usually it is not the standard treatment of care. Okay, very good. I would like, I have no further questions, but I would like to really, what I would like to tell you is I really congratulate all three of our excellent case sheet writing. It was an excellently written case sheet. Maybe in the history, as Dr. Prashant said, you could have added more qualified. The streamline பண்ணிருக்கலாம். But otherwise, your neurological point and all that, and all three of you had an equal participation. One person மட்டும் answer பண்ணிட்டு இருக்காம, Lavanya, Deep Lakshman, and Sudarshan, all three of you did a real wonderful job. And Dr. Arunachalam and your department have really mentored you well. You have done, and very confidently, all three of you answered. I'm really very happy. And God bless all three of you. And you come out with flying colors in your examination. That is my comment. Thank you very much.
Thank you, madam. Thank you, madam.
Thank
And Dr. Prasad, regarding the steroid, what's your comment, Dr. Prasad?
Sir.
Sir, it is not there in the guidelines right now, but still what we do is that if you have such a severe chorea, which is almost making the child bedridden, then you will not wait for other drugs to start showing its effects. So we give steroids at that point of time. If you have active carditis that is there along with this chorea, then also we tend to give this. Now, if there is an infection, then we choose IVIG over steroids. If there isn't any infection, then we choose a 6 weeks treatment of 3 to 4 weeks of 2 mg per kg and another 3 to 2 weeks of tapering. So that is what the usual regime we give. But yes, first we definitely, if it is not a very severe chorea, it is a moderate degree or a mild chorea, then we first see whether it is actually causing any debility or not. If it is not hampering any function, there is no treatment which is required. If it is hampering a function, then the first drugs would be, we choose one anti-seizure drug and one dopamine depleters. So we can club these two and give and see if there is a response in mild to moderate cases. But if there's a severe case, as it was the case here, the child, they was not able to, there was no mobility that was there. At least it was, I perceived it that way. So here, maybe the team was right in initiating steroids. And then it should go for
tetrabenazine, sir. Tetrabenazine.
Tetrabenazine is again is a presynaptic dopa depleter. People have seen that the response in dyskinesias and chorea is quite good. So in syndrome chorea, in other forms of chorea also, hereditary chorea also, we tend to give. But generally, we need to club the 1 or 2 drugs together. That is my personal experience. A single drug is not so potent. And the thing which I have found as very potent is haloperidol. But then it comes with an additional set of tardive dyskinesia. So you start treating a one movement disorder and you lead to another problem. So that is one issue. Therefore, people are moving away from haloperidol. But if things don't work, then we do give haloperidol to these children.
Lakshman, last question to you. Supposing, as sir said, if the patient develops tardive dyskinesia after haloperidol, what will you give?
Diphenhydramine.
Anticholinergics. Okay, that you give. And one thing I want to know from you, after starting steroid, was there a dramatic improvement in the symptoms?
Improvement was there.
Improvement was
After
noted.
starting steroids, there was.
Kades, you could have shown us one slide. After starting so many days of steroids, child, what is the improvement now? Now the improvements have dramatically improved. Have shown, it would have been really wonderful. That also you could have shown. But anyhow, it was really nice. It was a real pleasure being with you for the past 1.5 hours.
Yeah, Dr. Prasad, again, that what's the take-home message you want to tell that regarding this case now?
Okay, so this I must say I'll agree with Lakshmi ma'am that the case was quite well presented. There was a lot of participation. It was completely interactive. So one thing that I would suggest that when we have bedside, so then you focus on your examination findings and you try to build up a story based on your history and examination. So those things which can be evident on history, only they should come in the history. Those things which are to be identified in examination, they should come here. Now, a few points regarding this case is that as this case, before we started actually treating at our center, this child actually showed a very rapid improvement. And at that time, we are not sure whether there is a cardiac involvement is there. So someone actually pointed out this, that you should also keep a possibility of a functional component here. There was a rapid improvement that had happened. So unless and until you find a hard-hitting examination point, that can also be there in extrapyramidal disorder. So once you have ruled that out, and then you see that if that extrapyramidal involvement is acute or subacute in nature, insidious in onset, chronic progressive, or a rapid progressive. So all these things will help you. Now here you had a cardiac involvement, you are able to get to a diagnosis. If you don't have this, then these findings will help you to come out. It is a chronic progressive. So here the summary should say it was an acute onset, rapidly progressive movement disorder, which was flowing in nature, which was non-stereotypic, rapid, associated with an examination finding of a pansystole murmur over the mitral region. So this is how we need to establish that what is there. So that would help you in certain scenarios where things are not so forthcoming. So otherwise, I'm pretty happy with how the case progressed.
Thank you,
Thank you.
Dr. Prasanth. Yeah, and Dr. Ramesh sir, please your comment, please.
Another interesting case, well presented and nicely demonstrated the clinical findings by the students. Dr. Lakshmi asked almost all examination questions and the students faced them boldly. And Dr. Prasanth did a wonderful job. Actually, he said a beautiful approach to a CNS case, how history taking should be, how examination should be. Because the students started as if they knew the diagnosis even before the examination, because the complaints itself was almost like a definition of rheumatic chorea. So you should use as far as possible layman's terms are in patient's words only, and you should not give the diagnosis what is in your mind straight away. You should think of broader perspectives, more number of differential diagnoses, like Dr. Prasanth said. Even after I saw the video also, I thought there is also a myoclonus component also in this patient. So you should also do some lateral thinking, not hanging around only one diagnosis. Anyway, it's a wonderful presentation. It was a learning experience for us also. Both the moderators did a wonderful job, and Thuthukudi Medical College hats off to the students. Thank you, sir.
Thank you, sir. Dr. Srinivasa sir, please.
Yeah. A wonderful presentation, very good discussion, and excellent video this thing, presentation, so that we could see what is happening. And of course, madam always is like Lima Pauline, but array of questions one after another, covering entire aspect of
Thank you, sir.
abnormal movements. I always enjoy her interaction with the students, and of course, added attraction is of course our All India Institute stalwart, and everything has been covered, and we were totally satisfied with both performance and the way the case has been questioned and answered. Thank you so much.
Thank you very
Thank you,
much.
sir. Now I request Dr. Arunachalam sir.
Thank you, sir.
Yes, sir. Sir, I must thank the madam has stolen the show today. Was bombarding with the questions. I myself was a little bit nervous.
Anyway, all the
since
three
was
people were
but
answering. That's good.
That's right. Yes,
Yeah,
sir.
sir, but the students answered well, sir. That was very
Very
happy. I was very happy. And we have learned few things from our Prasanth sir, and we will modify, sir. We will make it in a more organized. We thought it is organized, and we will make it more organized, and then we'll make it better to do a CNS presentation. So that's a thing. So thank you for your
Very
suggestion.
satisfactory
And
performance overall. Yeah.
Thank you, sir. Thank you.
Extremely.
Sir.
Thank you, sir. Thank you, sir.
Thank you, Rajendran sir.
Yeah,
Thank you, Srinivasan sir and Ramesh for your useful inputs, sir. Ramesh sir நிறைய கேள்வி கேட்டுருக்காங்க சார் உள்ள.
ஆமா, அவர் கேட்கும்போது நான் பேசாம இருப்பேன் நான்.
Thank you very much, sir. Your presence.
Thank you, madam. Thank you, Dr. Lakshmi.
Thank you. On behalf of IAP TNSC, I thank today's chairperson, Dr. Arunachalam sir, and Thuthukudi Medical College students. They presented very nicely. And I thank Dr. Lakshmi madam and Dr. Prasanth. They have done a wonderful job today for the moderators. And I thank judges, Dr. Srinivasan sir, Dr. Ramesh, who has asked a lot of
நான்
questions.
பிறந்த ஊர் சார் தூத்துக்குடி.
Yeah. So I thank all the students who was presented, and I thank all the faculties as well as a lot of postgraduates watching the program also. Once again, on behalf of IAP TNSC, I thank one and all. Thank you very much.
Thank you, sir. Thank you,
Thank
sir.
you.
Bye,
Good
sir.
night, all of you.
Thank you, sir. Thank you,
Very
sir.
satisfactory
Good
day.
night.
Thank you.
Thank
Good
you,
night.
Thank you.
Thank you, sir.